Good evening, everyone, and thank you for attending AACP's webinar with Dr. Angela Tenholder on ALF Therapy, Navigating the Road to Success. My name is Cassandra Carlson, and I will be hosting the webinar on the back end. Attendees are encouraged to submit questions using the Q&A box. Questions will be addressed at the end of the presentation. Before I introduce tonight's speaker, I wanted to briefly mention AACP's upcoming events. We'll be hosting a webinar on June 25th on laser beams versus diode Cowtree in oral soft tissue surgeries with Peter Vitruk. Don't forget to register for the upcoming clinical symposium in Lexington, Kentucky on August 6th and 7th. Now, it's my great pleasure to introduce our speaker for tonight, Dr. Tenholder, who is a general dentist of over 25 years, mother of 3 and wife of an Air Force veteran, as well as founder of Synergy Dental Solutions, the Synergy Academy, and ALF InterFace Academy. In addition, she is currently serving as a board member for the ALF InterFace Academy and the American Board of Craniofacial Dental Sleep Medicine. Her professional credentials include Diplomate status in the ABCDSM, as well as fellowship status in both the Academy of Craniofacial Pain and the Academy of General Dentistry. By working close with the inventor of the ALF family of appliances, Dr. Darick Nordstrom, she has benefited from the opportunity to apply the unique combination of professional guidance and personal experiences for the ALF therapy professional community. These include an online educational platform, annual conferences, both entry-level and advanced courses, and the innovative and supportive therapies of SmileLase and BabyLase. With that, I'll hand it over to Dr. Tenholder to take it away.
Hi, thanks, Sandra, for welcoming me to the AACP webinar. And what I am excited to do tonight is introduce our professional community to what I've learned about ALF therapy and how to help everyone on the road to navigate to a more successful understanding of what ALF is, also known as ALF therapy. So my journey with ALF therapy has been an interesting one. I started as a patient and now I'm a provider. And ALF, or ALF, is also known as advanced light force therapy and advanced light wire functional therapy. And it's been called a bunch of different things, but it all comes down to ALF. I decided to choose the subject code tonight of emerging diagnostic or therapeutic techniques because ALF is always emerging. There's always something new coming about through our ALF therapy educational opportunities, and especially once you guys get to understand more about Dr. Darick Nordstrom, you'll understand why. So tonight we're going to learn a little bit more about the origin, designs, and importance of the basic oral neurophysiology behind ALF therapy and the different options for therapeutic interventions offered through ALF and supportive therapies, and also to gain an appreciation for the dynamic complexities of human function that we deal with in the ALF community that some other providers and other techniques do not embrace in their approach. But I want you to understand where we're coming from. This is me disclosing that my organizations that I am passionate about are the ABCDSM, where I'm the credentialing chairperson, and the AACP and the educational committee. I also own my business, and I'm the president of the Synergy Academy, which teaches the ALF courses, and the ALF InterFace Academy, which credentials our providers, is a not-for-profit organization that hosts our annual conferences. And ALF therapy has a long and rich past, has an exciting present, and an even more exciting future. But GPS, what we call ALF GPS, is always something that we focus on, which is when we type a GPS into our phone or our computer, we want to know where we're starting and how we're going to get there. And to be able to understand ALF, you have to understand Darick Nordstrom. And it was developed by Darick almost 4 decades ago. And it's been interpreted by several different ALF instructors. Some of them received a few days of training, and some did not have any training at all by Dr. Nordstrom. And that's created some confusion in our ALF community and in our professional understanding of what ALF therapy is. In addition to developing ALF therapy, Dr. Nordstrom is the original designer of the dorsal mandibular advancement dental sleep appliance, originally created as the Nordstrom CC and then into the Nordstrom appliances. He has also developed OralLase, which is currently known as MyLase, and has evolved into SmileLase and BabyLase, which is a supportive therapy using non-ablative laser treatment and it's fantastic. But once again, this is all part of the journey of being an ALF provider, is to understand the concepts. And ORLAs and ALF come from the same concepts. And so, as I mentioned, we're going to talk about the history for a moment, because the simple mechanics that began this journey in ALF and is now systems integration is part of the overall comprehensive and global understanding of what ALF therapy is intended to be. The man who invented ALF actually started his journey in understanding sleep at age 10 by studying hypnosis. His first nerve stimulator at 14, and Gordon Christensen was his youth leader, and together they experimented with electrode placement and frequency to induce sleep. And Darick originally wanted to go to medicine, and Gordon convinced him that dentistry might be a better choice for him, and I'm glad he did. Still, even before he got his bachelor's degree, he attempted to track electroencephalogram information during hypnosis using polygraph technology at Brigham Young. Then he finally got his bachelor's degree. And then he began working with Joint Propulsion Laboratory to use their biotelemetry equipment to monitor sleep. But there wasn't enough money to go around. It wasn't important to them back then. The focus is a little bit different today. And then he finally got his dental degree at USC. Then he started studying with functional appliances to avoid extraction. And then in about 1982, the ALF appliances were born as a consequence of collaboration with osteopaths and oral myofunctional therapists, trying to figure out what kind of dental appliance actually supported health in cranial function and neurology, as opposed to those who might not have supported as well with their osteopathic and palpatory feedback. And then some of the other dental sleep medicine history is Peter George. He introduced functional orthodontics to sleep disordered breathing in the mid-'80s. And shortly after that, Dr. Nordstrom developed his first dental sleep appliance, and he used it to treat Hollywood celebrities that were very, very particular about what they were willing to wear and what they weren't willing to wear. And he had some huge successes with it. He published that in the Functional Orthodontist Journal, and then he went on to present this design from 88 to 96 and different designs as well. But in 89, he modified the CC design to become the Norse Nor 2 and the Norse Nor 1, which the goal of these appliances was to support felt's functional envelope in a therapeutic position without encroaching on the tongue space, which is a huge thing for ALF therapists to grasp, understand, and embrace. And then he presented them in the Taylor Clinic at the AAFO. In the 90s, the Norse Nor 2 was copied by a provider who learned about the design from Dr. Nordstrom at the AAFO and renamed it Dorsal. And then that was taken on by Somnodent and used in other oral appliance therapy techniques. And NS2 designs then evolved over time into what they currently are, which is ALF and Omni designs to stimulate premaxilla, nasal breathing, and facilitate autonomic nervous system function. And we use heart rate variability to verify that. And what does all this mean? It means the creator of ALF therapy and the developer of the mandibular advancement dental sleep appliance has known all along that sleep quality as well as quality of life goes beyond the structural assessments of the airway. And during our ALF therapy journey in education, we do everything we can to make our providers understand that the influences of their treatments are dynamic and functional in nature and go well beyond the airway into sleep physiology. And as we all know, life is complicated, dynamic, and constantly evolving. And not everything that counts can be counted, even though we sure do try. And ALF therapy is distinctively different from other appliances. And it's often misunderstood because many of our professional colleagues don't understand the complexities of osteopathy, functional and neurological concepts that are absolutely fundamental to the goals of treatment. And sometimes it's not easy to be an ALF provider because there's a lot of people that don't understand it. And honestly, I've been shamed before professionally. People have called it snake oil, cult, and all these other things, but it's so far from the truth because we're so founded in science, and it's just a simple misunderstanding. And this is one of my favorite diagrams about the evolution of knowledge in field and confidence. And when we got out of dental school, we thought we knew everything. And then we kind of learned that that's not the case. And I would say that everyone that's been on this ALF journey is right in the middle of that thing, that graph. There's always more to it than we think. I think we have learned that this last couple of years during this COVID crisis, that we don't know everything think that we know. It changes and it evolves. And we go from, I'm never going to get it because it's complex, to trust me, it's complicated. And Darick Nordstrom and I are in the trust me, it's complicated most of the time. And navigating the road to success is done by honoring the journey and understanding that human development, function, and physiology are complex, dynamic, and multifactorial. So why try to simplify it? But I'm so grateful that the audience that we have tonight in the Academy of Craniofacial Pain, we get it. We deal with a complex patient. And we've often tried simple approaches and then it doesn't work. So we have to find other opportunities. And sometimes it's just we're pushing on a door that needs to be pulled open. Sometimes it can be easier. And the primary motivation that was created with ALF therapy has always been to work with the natural forces that guide the function of the world that we live in, and understanding the map and the owner's manual that dictate our journey as humans. And that's the natural forces within us that are the true healers of disease. Hippocrates said it thousands of years ago, and it's true. Because what we deal with ALF therapy is honoring the common sense approach to supporting function and development by harnessing the power of the natural, repetitive, rhythmic signaling as the key to success. And by directing these forces that it can either help or harm the wellness of the patient. ALF therapists, we get to see, honestly, miracles on a daily basis. And once you see it, you can't unsee it. It's completely addicting. The things that our patients do and the obstacles that they overcome is just crazy cool. Because a lot of times, as Tony Robbins said, you need either inspiration or desperation to make a change. And it's truly inspiring to be an ALF therapist. So a lot of people want to know why ALF, why is it so different? And these are the concepts that we focus our therapies on. Oral neuromial function, not just the function of the muscles, but the neurology that drives it. We do focus on cranial osteopathic principles because we believe that is one of the major truths of why ALF therapy is successful for so many patients. Dental trigeminal influences, and then we look at the motion of the body, the fluids of the body, and that's just not saliva, it's cerebrospinal fluid as well. The frequencies, not only frequencies of sleep, but we use heart rate variability and a lot of biometrics to be able to gauge the progress of the treatment of our patients. And we honor the rhythms of the body because that is what we're talking about. And the rhythm generating centers of the brain are so important to us. And we constantly talk about that because that's what drives sleep and function. And that is one of the major aspects of wellness that are important to us. ALF objectives include addressing the dysfunctional oral neuromyofunctional patterns that our patients come in with as a baseline. And we customize our appliance design and our supportive therapies to where they are. So we meet them where they are and gently encourage them to evolve and grow and overcome whatever deficiencies got them to where they didn't want to be in the first place. We ensure that the cranial mechanism and the accompanying neurological patterns are supported before initiating aggressive arch development. A lot of people are like, what is a cranial mechanism? And what neurological patterns go along with those? And we'll get into that a little bit more in the presentation. But as a general rule, imagine that the bones of the cranial vault are tectonic plates, like we have under our feet every day that we don't feel them moving, but they're moving. You can feel them move in an earthquake, and you can see them crash together when they form a mountain range. And a lot of people, just because they don't feel the cranial mechanism, they don't believe it's there, but that's not true. Think about the moon and how much influence it has over what we do. We can't see the forces rising our oceans up, but they're still doing it. And that's one of the things that is hard sometimes for ALF providers to get our patients and our colleagues to understand, is that the cranial mechanism is a living, breathing, dynamic thing, and we affect that directly and indirectly through any dental therapies, but we do it on purpose with ALF. We provide gentle, consistent rhythmic support to encourage arch and orthopedic development while guiding the natural forces of the mature swallow and balanced mastication to support that patient. We avoid aggressive dental alveolar expansion until the patient can overcome their obstacles, and those include unresolved trauma, which there's a lot of trauma that our patients are dealing with that causes fascial restrictions and neurologic obstacles. And that creates sleep architecture challenges, nutritional deficiencies, which impede effective osseous remodeling because if a patient is not sleeping well, they're not growing well. We're not going to grow a face and rehabilitate a body unless we understand the implications of effective sleep. We support the patient and the parent as therapeutic partners in providing self-care techniques to assess and address structural and functional restrictions. It's a huge part of our treatment and our therapy for our patients is to empower themselves to do their therapy and do their work at home. And we are constantly communicating and collaborating with our interdisciplinary healthcare providers, osteopaths, physical therapists, chiropractors, oral myofunctional therapists, occupational therapists. There's so many things that we have to understand to be able to support our patients because we are in it for the whole person, for the whole lifetime. And back to the road trip analogy, think about blind spots. We go to change lanes. So most of us are pretty comfortable in our lanes most of the time. But then what if that lane doesn't work for us and we want to scoot to a different direction and check out another lane? But we got to make sure that we're not having a blind spot when we do that. And things to think about when it comes to blind spots are a lot of us are wondering, what is evidence-based medicine? And then think about, why do we just follow instead of lead? Because honestly, following is easier. Just to do what someone tells you to do is a lot easier than thinking through things. And does every patient respond to the therapies the same way? No. And think about it for a moment. Are we doctors or are we healers? And how well do we understand the physiologic terrain of our patient beyond the linear static measurements that sometimes come with cephalometric analysis, a volumetric airway assessment, which are static? And honestly, some people get really overwhelmed right now and they just can't, they're like, I like to like measurements, like how far do I need to turn that screw? How many turns per week? Is it a quarter of a milligram or millimeter per screw and turn, and how do I do it? And they just want to do math. And that's why it's not for everyone, but those who love it, love it. And I'm one of the girls in the front row here. I love this part of what I do. I think and I change and I grow and I change my mind because I am an evidence-based practitioner. And this NCBI article is fantastic because it talks about the evidence-based medicine is the conscientious, explicit, judicious, and reasonable use of modern best evidence in making decisions about the care of individual patients. So one of the things that we have at our fingertips at all time in the ALF therapy community is the volumes of research that Darick Nordstrom has gathered for us to support understanding why it is what we do is effective for patients and how to go through the problem-solving skills of designing our patient care. And we look at literature. We constantly are reviewing and evaluating literature. And the practice of evidence medicine is a process of lifelong, self-directed, problem-based learning in which caring for one's own patients creates the need for clinically important information about diagnosis, prognosis, therapy, and other clinical and healthcare issues. It is not cookbook with recipes, but it's good application for cost-effective and better healthcare. And this is kind of the ALF therapy jam right here. That's where we live. Front row, helping our patients live better lives. So the question is, where are our blind spots as providers of traditional dental structural therapies? It's often found as a therapeutic model of wellness. We get so focused on what it is that we do that we forget to look elsewhere. And that's why Dr. Nordstrom decided to refer to it as ALF therapy, because it's not orthodontics. We're not just moving teeth, and it's not just an appliance, because the goal of ALF therapy is not only to move the teeth, but to improve the lives through naturally enhanced functional improvements. And a lot of people, they learn a technique, they get comfortable with it, which is fine, but that's kind of like the hammer and the nail analogy. And in ALF therapy, we're looking at what Plato said, with the cure of the part should not be attempted without the cure of the whole. And the Dalai Lama had a quote that I love, especially with regard to ALF therapy. And it says, if you think you're too small to make a difference, try sleeping with a mosquito. Because ALF therapy might be small, but it's powerful. The symbol of ALF therapy is a hummingbird, and Dr. Nordstrom shows that because those light repetitive forces create a force of nature in a beautiful, delicate way of addressing function. And it's one of the most hygienic and petite of dental appliances, and it's almost invisible to the observer. It doesn't affect speech, it doesn't affect swallow, and it doesn't make it hard to keep the teeth clean, which as a general dentist and a mom, it's kind of important to me. And a lot of people think ALF is just one appliance, and that's not true. And these are just a few members of the ALF family of appliances. And they look all different based on the patient's needs. The one on the upper right is the patient doesn't even have teeth. It's a neonatal ALF, and it can do palatal development in an infant. Design reasons and responsibilities include the things that are most often associated that people understand and maybe don't understand about ALF design. The anterior omega loop is a little loop that goes right over the incisive papilla, and it establishes and encourages a functional midline by targeting the most powerful and influential muscle of the body, which is the tongue. The cuspid crescents are something that have been overused and improperly utilized for a lot of ALF designs because they are intended to help patients overcome trauma. And when the cranial vault is not motion friendly as what we want it to be, those cuspid crescents stimulate the breathing reflexes and help trauma release, and that's what they were intended to be. But they're often misused, and sometimes when someone uses an ALF appliance, it's like the canine teeth come into the room before the patient does, and that's never a goal of properly performed ALF therapy. On the auxiliaries, when you hear that term, it's the well-designed use of Essex and acrylic to complement the body wires and amplification or modification of the patient's oral neuromial function. The body wire is made of elderloy, which is an alloy that is a very, very specific alloy that we found honors the frequencies of the body, and it's a very resilient wire. But it's different for every design, and the design is depending on the patient. And also certain teeth can take certain forces and other teeth can't take certain forces, and those are all part of the design considerations of ALF. And there's appliances in the ALF family that are not even with a wire, so we go wireless. The Essex and EVA-based appliances include the ALF NLA and the Nordic Positioner. They can complement and go in conjunction with the wire-based appliances, or they can be used as standalone. The posterior omega loops are another critical aspect of proper design that's been misinterpreted, and it's at a great detriment to the integrity of ALF therapy, and that's something we're going to be going over through our courses to let people know why the posterior omega loops are supposed to be in a certain place instead of where sometimes they're misunderstood that they are being placed in many, many appliances. And the concepts of oral neuromial function include myofunctional therapy, which most of us are familiar with, applied neurology, which most of us are curious about because we kind of know that we affect neurology, but sometimes we don't really understand how and why. Cranial osteopathic principles, which I mentioned before, because if you think about the box as the cranial vault, the contents of the box is neurology, and that's how we perceive our environment and how our body works, and that's what actually controls the functions that we deal with every day. It's not the size of the airway, it's not the location of the teeth, it's what the brain perceives about those things that's important. Because dental malocclusion, we all know, can contribute to neurological issues. And when you think about a sailboat is driven ideally by natural forces of the wind in the sail. And the face is naturally driven by the tongue to the palate. And this is one of the most critical components to understand about successful ALF therapy, is making sure that tongue is on your side and not against you. And this is Dr. Nordstrom's quote that I wanted to share with you, because this is one of the truths that we all struggle with those of us who deal with craniofacial pain and dental sleep medicine. In a functionally supported system, the oral neuromusculature reflexively maintains the airway dimension at the right volume for optimal O2, CO2, and nitric oxide levels in balance. We shouldn't have to do all these dental sleep appliances, and that's why Dr. Nordstrom didn't patent his things and focus that's the only thing he does, because there's so much more to it, and that's where ALF therapy came in. And when you look at the Grand Canyon and the amount of effort that it took to be able to do that with a nature-based approach, and how much effort it took to overcome that with the Hoover Dam, think about the forces that it takes to overcome the forces of nature. So in ALF therapy, we like to think we're working smarter and not harder when it comes to working with forces and getting them on our side. And ALF is kind of like the apple to a lot of the other oranges out there with dental orthopedics. There's rigid and rhythmic, and we are rhythmic. This is some of the supportive literature that goes over the rhythmic nature of why ALF is designed the way it is and why this modulation, the oscillatory component of micromechanical strain is so effective, why we need to use lighter forces and get incredible results. But if that tongue isn't connected to the brain with a neurologic pathway that supports ideal function, we're never going to get there. So that's why it's oral neuromial function, not just oral myofunction. Navigating the path to success is always our goal when we're a provider providing clinical care. Think about where you are with your structural diagnosis of your patients. What kind of baseline oral neuromial function do they have? Do they have a tongue that's able to elevate? Do they have lips that are pursed and pulling that mandible back? Do they have a hyperactive mentalis muscle? And is the buccinator overactive, creating crowding? And where are you going? What are your treatment objectives? What do the patients want? Not every patient wants to have a therapeutic model of craniofacial development. Some of them just want to get their teeth nice and pretty so they can have the graduation pictures. ALF therapy might not be for them. Screen your patients, choose selectively. But think about how you're going to get where you want to go. Are you just going to move teeth, or are you going to try to understand why the teeth moved in the wrong place in the first place? And we teach our students to choose an appliance based on those predisposing factors and work with them. And one of the criticisms of ALF is that it takes forever. It doesn't necessarily, but healing does take time. And learning takes willingness to be open to new possibilities, because what we believe in ALF therapy is that direction is so much more important than speed. But wouldn't it be nice if that Staples easy button were around every corner, when every patient would come in, we just say, we're going to push the easy button for you. Those of us who deal with complex patients know that that's not a reality. ALF therapy, the reality is that we do honor and amplify the mature swallow pattern that creates resilience and recovery. We enhance the motion of the cranial vault, removing waste products from the brain, and knowing that stage 3 sleep is so important in that, and making sure that the cranial vault is not structurally restricted. That's one of the big research projects that we really encourage our students to be able to learn, that how important it is to understand sleep when it comes to dental mechanics. And we aim to provide reflexive and intuitive proprioceptive feedback to encourage ideal tongue function. I have patients that can do oral myofunctional therapy better than anyone on command, but they struggle to get a reflexive swallow. But when we put the ALF in and they're reminded all day long, every day where that tongue is, the conversion to that mature swallow is much easier. ALF therapy can treat a patient of any age. We talk about the littles, the middles, and the bigs, and we break our training up according to age. Littles are 0 to 5, middles are 6 to 11, and bigs are 12 and over, because the littles, they have their own set of opportunities and challenges, and it's amazing to get a child at 3, 3.5, and treat them and just watch them blossom. It's fantastic. The middles is where most of us are looking at dental facial orthopedics as our goal, to get them while they're growing. But after the age of 12, we have most of our facial growth done, and then we get into the complex compensations that come along with impaired growth. And there are so many designs that are part of the toolbox. These are just a few. So in the littles, we have neonatal ALF, pedo ALF. We have a wavy wire design for mandibular development that isn't even a lingual wire. It's a buccal wire. And the 6 to 11, just a few of them are ALF for development, which does not include cuspid crescents. Pedo class 3 and omni designs. We have the wavy wire for class 2 correction that is almost like an orthotic for those of us who treat temporomandibular joint disorder. And in that, we can translate into the 12 and overs for ALF for development, trauma release, NLA, and Nordic positioner, which is a fantastic sleep appliance. And this is what most people think about when they think about an ALF appliance. And this is the ALF for trauma release. The cuspid crescents are those little blue wires on the lingual of this drawing on what represents the canine teeth. And these little additions should rarely be used on children. They don't need that kind of force to be able to stimulate the breathing reflexes and unlock the head in the case of those cranial strain. And a lot of people will just say, well, make me a lower ALF, make it look just like the upper one. That is not a proper design for the lower arch. And the position and shape of the posterior megaloops is another thing. We should be as close to the molars as humanly possible. They are intended to represent the cusp of cerebelly and the brain recognizing this is a normal, natural shape for them so the body doesn't feel like it's foreign. There's other reasons, but that goes into a lot more detail that you'll get into if you decide to learn more about it. The intention of the trauma release design is to address the physical trauma that affects the mobility and sutural relationships between the cranial bones, those tectonic plates in our head that I was mentioning earlier. It also helps with treating traumatic brain injuries and getting that cranial mobility. It helps overcome some of the obstacles created for some patients with rigid and retractive dental facial orthopedic devices, and it can be used very effectively for craniofacial pain. That was my entry point. I entered this journey not knowing what I was doing and desperate, and it saved my life. It took me from antidepressants and painkillers to feeling better now at 50 than I did at 35. It also can help overcome obstacles with chemical, emotional, environmental trauma. And I know in dentistry we have to watch scope of practice, but if it's a happy coincidence that we're straightening teeth and the other things happen to get well at the same time, that's one of the joys of my practice. But also the trauma release design has a little bit more support for the reflexes of breathing and tongue function, often negatively affected by trauma, and the fascial restrictions that can come into play from active retained primitive reflexes, which there's people right now going, well, what the heck is an active retained primitive reflex? That's a whole nother lecture, but it is a major part of our ALF therapy education to understand that when you're stuck in fight or flight, the fascia will always be tight. And we train our providers to understand how to identify and overcome these restrictions for the patient so our treatment can go more smoothly. These are the additional laser therapies that I'm just going to mention really briefly because they are recognizable with most ALF providers that have the opportunity to take these laser courses. They're learning that it is such an amazing adjunct to ALF therapy. And it's a specific frequency. The BabyLase is performed on babies age 0 to 2 to help them increase the neurological connections often caused by trauma and to decrease the fascial restrictions that are often associated with decreased tongue function. Oral SmileLase was developed as OralLase, but trademark legalities prevented us from securing that. So we're oral SmileLase. So we're treating the muscles of the mouth with a laser. Some frequently asked questions that I get as an ALF educator is, does an ALF dentist have to work with an osteopath to address the cranial strain? And what are cranial strains? As I mentioned earlier, the bones of the head are supposed to be moving and they're supposed to be fairly symmetrical. They're supposed to be in concert with each other. Sometimes cranial strains happen where the bones are not moving freely and the neurology gets impinged. Entrapment neuropathy, especially in the sphenoid, is one of the things that is very detrimental to patient wellness, and that's one of the things that we want people to learn about. Another big one is, where's the research? Is there any proof that ALF produces anything more than just expansion like the other expansion appliances? And that's been one of our biggest challenges because most ALF therapists are clinicians. We're not going to go to a research facility. We know that clinical equipoise is an inherent limitation of human research. We perform treatment. We don't necessarily do research. We thought about getting an I or B together a couple of years ago, and with all the different providers doing different things and clinical equipoise being part of our decision, it was really, really a big obstacle to overcome. I can tell you I have data. I can also tell you I don't need to prove myself to anyone else. So once you start doing ALF therapy, knowing that there's very little risk, very little harm involved, why not? So research, if you're going to ask an orthodontic school to do anything other than move teeth to be able to get the research, it's going to be a little bit of a challenge. So I know that that is an obstacle for a lot of people. They need to see the research to feel comfortable doing a procedure. And that's fine. If that's where you need to be, then know that there is research on it. But there's not going to be the same as you would with something that is more easily measured, like an RPE, where you know exactly how many turns of the screw you're doing to get the results that you're getting. Is there any proof that ALF helps sleep and airway? In theory, you should already know that it does, based on what the information is out there that you can extrapolate from the reasons why, the principles of why ALF works. There are some of my patients that have never slept very well until they get an ALF in their mouth, and they only use it for sleep. Some people, most people, when you put the ALF in, I just wait for it. They say, is it weird that I'm breathing better right away? And sometimes it takes a week or so, but they're always like, wow, I breathe so much better. Why does this little wire help me breathe better? Turns on the reflexes of nasal breathing. It's very powerful. What is the best place to start with ALF, kids or adults? I'm going to say kids for the most part. They're a lot more resilient. Adults can be complex. So that is one of the big questions we get. And then a lot of people, especially in the era of COVID, are there online training options? Yes, we do have a lot of online training opportunities. In fact, our foundations course is completely online, on demand at this point. And we do offer credentialing. Another one is an ALF just another expensive expansion appliance? It can be used as an expansion appliance, but that's not its intention. Which appliance should be chosen for what patient phenotype? That comes with training and understanding, and also your comfort level. You might start with some basic appliances and then graduate into the more complex. You just got to know what works in your hands and be in your lane as an ALF provider. And the most frequently asked question that I get is, can you just please keep this simple and tell me how we should bend the wire? Should I bend it 1.5 millimeters at this bend and then 1 millimeter at that bend? That is something we go over in our home courses about how to assess the body's neurology and the reflexes to know how to bend the wire to best support the patient. Because if you're fortunate enough to work with an osteopath, that's awesome. Most of us aren't. So we've developed other resources for our ALF providers. And where can one start learning without feeling overwhelmed? That's a great question. So we developed resources that are online that you can go through websites and learn. And then we do have our online educational options. It's a great place to start because you can take your time. You can rewatch a video if you don't understand it. You can call someone and ask. We have a great supportive community of providers that is willing to help. And another huge one is Dr. Nordstrom is hard to follow at times. He's so smart. He's so brilliant, but we don't understand what he's saying. Can we take a course that makes it all easier to understand? We're doing our best. Yes, he is like the Ferrari going 100 miles an hour in the fast lane, and everyone else is trying to keep up because he is our leader and he's our creative developer, and he is a brilliant, amazing man. And we do have ways to make it simpler to understand. However, we're not going to oversimplify it because that is something that has happened more times than we're comfortable with. And that's one of the reasons that Dr. Nordstrom and I have collaborated in teaching, because it's unfortunate that some people have felt the need to simplify it and then claim that intellectual property that Dr. Nordstrom developed as their own. And regretfully, there's a lot of practitioners that have taken courses and they thought they were learning ALF. And then when they hear Dr. Nordstrom speak, they realize there's a huge difference between what he says and what they've learned in other courses. And that's why we're working so hard to be able to get the truth out there, because there are some patients, and there is a reputation of ALF that ALF doesn't work. But there's also reputations that religions are fanatics and all different things. You take a great idea and you put people in the middle of it, and if you get changed from what it was to what it becomes, then it may not be what it was intended to be. Because just okay is not okay, and we're out here to try to get the truth out, because it is much easier to do a job right than explain why you didn't. And we all have choices to make. As I mentioned earlier, ALF is not for everyone, but most of us are in the arena of what we're talking about, the Teddy Roosevelt quote that Brene Brown talks about when she speaks, which I highly recommend you guys look into her work, because she's fantastic. Patient care is complex. And honestly, I hear a lot of people that are like, oh, ALF doesn't work, it's a cult, whatever. But if you're not in the arena getting your butt kicked too, honestly, I'm not interested in your feedback, because if you don't know that it doesn't work because you haven't tried it, don't tell the rest of us that it doesn't, because I'm telling you that it does. Because ALF is kind of like the Swiss Army knife tools, has infinite possibilities, has endless opportunities. As Napoleon Hill has a great quote, because a lot of people are like, I don't even know where to start. And basically, don't wait. The time's never going to be just right. Start where you stand and work whatever tools you may have at your command, and better tools will be found as you go along. And not only do you have our ALF community that support you, but you have a lot of online resources as well, and a lot of research and literature to read through if you're interested. And there's about a Walgreens in every corner. There's not as many Nordstrom stores. There's not a lot of people willing to do what it takes to get the quality education that goes along with being a comprehensive ALF care provider. It is much more than a 2-day course or watching a couple videos online. This is a lifetime of learning. So that's why there's not a lot of us. But that's why I love it, because I love my community of dedicated providers who get it. And there's not a lot of us, but there's becoming more and more of us. And that is a segue to my next, I'm not going to say shameless plug, but it is a plea to our Academy of Craniofacial Pain community to join us in the American Board of Craniofacial Dental Sleep Medicine. Because getting credentialed into ABCDSM is a higher level of status, honestly. To do what it takes to get a Diplomate in the ABCDSM, it's reserved for those who set themselves apart, who are willing to do the extra, because we do want to know not only about sleep, but we have in-depth knowledge of temporomandibular function and dysfunction. And the recognition that comes along with that title of highly educated, experienced, and dedicated providers is a coveted distinction in the medical and dental communities. And we welcome you to join us in our mission of serving patients. And I know this is about ALF therapy, but when you think about all the things you've just heard about sleep that you might not have known before, these are the same kind of things. Not that we teach ALF therapy in the ABCDSM. I want to put that disclaimer out there and bringing them together just to get some awareness for some of the educational opportunities that are out there and to welcome you into the ABCDSM. This is a poem that I want to close with because it's super important. We've been using this in our ALF courses for years. And this is a Ralph Waldo Emerson quote that really represents what it is like to be an ALF therapist. And that's on the road to success. That's the name of my presentation. To laugh often and much, we are an ALF family. We get together for conferences and we are a great group of people. To win the respect of intelligent people and the affection of children. To earn the appreciation of honest critics, and endure the betrayal of false friends, to appreciate beauty, to find the best in others, to leave the world a bit better, whether by a healthy child, a garden patch, or a redeemed social condition. To know one life has breathed easier because you have lived, this is to have succeeded. And all of these things are what we embrace in our ALF community. And we kind of decide to stay in our lane most of the time. And we're comfortable there. We do look at everything, but when you think about life, where we're headed is more important than where we've been. The windshield is always bigger than the rearview mirror, and we welcome you to be part of our windshield. So that is the ALF therapy journey. I'm going to go ahead and welcome anyone to ask questions at this point.
How can we correct the base of the skull?
Well, the base of the skull, are you referring to the spinobasilar symphysis, occiput? Is that the area that you're referring to?
Basically, on the when you put your fingers base of the skull on the prosody, the base of the skull is one side is higher than the other side.
A lot of that depends on the age of the patient, but what we're doing with ALF therapy is we're understanding why the occiput might be asymmetric in the cranial strain pattern that occurred. And a lot of that comes from early cervical strains and how the position of the upper cervical spine is forming around those cervical strains. A lot of it is from birth trauma. So when we get the tongue moving and we get the tongue restrictions, the fascial restrictions, the neurologic restrictions, and we provide this gentle rhythmic motion of the ALF, some of these restrictions can loosen up. And that is one of the things that we always look for in ALF therapy, is to make sure that the bones that had restrictions that prevented them from being symmetric, we do everything we can to identify the obstacles, remove those obstacles for the patient. But a lot of it is the tongue, because if the tongue is functioning at midline, and the tongue is functioning to the best of its ability, those cranial strain patterns can be alleviated much easier than they would be without it. I hope that makes sense.
Absolutely. Thank you so much.
You're very welcome. One of the things that we find a lot is that it's a little overwhelming sometimes to hear a lot of these different concepts. And people do think of questions afterwards, or they don't feel comfortable asking them in public because they don't feel like, they're confident in them. And that's honestly why our ALF community has 2 Facebook groups. One that is open to pretty much anyone who wants to join, that people could ask questions about ALF therapy. Another one that is more private for our providers to be able to ask case-specific questions on patients. And that's always something that's available to people if you're interested in joining the ALF community. It's a great opportunity to learn. And the online courses that are available, they're through a digital platform called Digital Chalk. And basically, when you register, you get access to this platform and any courses. And we have a bunch of different material that's available that we open up, based on what the providers are wanting at the time. But the online courses, all of the content, the course outlines are available by going to that ALF Resources tab and going to the tab where it talks about the provider resources and educational opportunities. And you can look through all the different courses we have available.
Okay, wonderful. Thank you.
You're welcome.
Well, if we don't have any more questions at this time, I thank you, Dr. Tenholder, for that really informative presentation. That was a lot of great info in a short amount of time.
Thank you very much.